thing. So our main objectives will be, learning the clinical presentation of various psychiatric disorders, and then we'll do some pharmacology and electroconvulsive therapy, and question and answers will be in between the case scenarios itself. Okay, after we learn a topic. So yeah, we shall start with the somatoform disorder. So what is somatoform disorder? So somatoform disorder, as the name itself suggests, see, there is going to be, one second. Yeah. Okay. So there is going to be mainly somatization of the symptoms. What do you mean by somatization of the symptoms? That is, here the patients will have an, inside an aggression or some stressor that will manifest as a bodily pain or a bodily disorder. So usually these patients keep coming to the doctor, okay, for multiple symptoms. Sometimes they may have some GI symptoms such as belching, pain, vomiting. Sometimes they may present with skin symptoms such as burning, itching, or tingling. There can be times where they can present as hypomenorrhea, oligomenorrhea, or there can be menorrhagia. Sometimes they can have sexual dysfunction. So these are all very vague symptoms which, when evaluated, will not have any identifiable cause. For example, the patient will be having severe belching or retching, and they do an endoscopy and they find it all to be normal. Suppose, for example, the patient presents with oligomenorrhea. That time when they do all the hormonal profile, and then they do a USD pelvis, everything will turn out to be normal. But these patients, if you tell them that, so you have been having all the symptoms, it is all related to your mind and not the body, they will usually not be, you know accustomed to it. They don't like to accept that whatever the disease that they are suffering is because psychological, rather than structural disease or some problem with their metabolism. So the main diagnostic criteria will be in this paragraph. So they'll have multiple physical symptoms at least for minimum 2 years. So to label a patient as a somatoform disorder, you have to have these symptoms for 2 years, and they'll be associated with multiple hospitalizations. So they keep coming. They'll have, usually these patients come with big OPD files, big inpatient files. Sometimes, they will usually would have undergone multiple surgeries as well, and you can see multiple scar marks, laparotomy scar marks. But still, when the surgeon opens the abdomen, there will be nothing formed. So, in summary, somatoform disorder is a disease where the patient exhibits multiple physical symptoms for more than 2 years. And here, the main treatment lies in empathy. If the doctor doesn't believe this patient is having actual belching, actual pain abdomen, the patient is never going to be better. And one thing to be remembered is, they truly feel this pain. It is not like they are, malingering, or they're doing it for some reason. Okay, so that is mainly somatoform disorder. Next, we have hypochondrosis. The famous Hitler actually had hypochondrosis. So, what is this hypochondrosis? These patients believe that inside they have a very serious illness, and this can such as, cancer, HIV, or anything, and they keep repeatedly going to the doctor asking them to test for cancer surgery. They would have got a multiple PET scans, multiple biopsies, and all of them would have come negative. And as soon as the doctor says that, no, the results have come negative, so you're free to go, you're not suffering from any breast cancer or any uterine cancer, the patient will very conveniently change the doctor. So all these patients, instead of going to a psychiatrist, they do this something called as doctor shopping. They keep jumping from one doctor to another doctor. So they will never accept reassurance or negative results. Then in the same somatoform disorders, we have another disease called as conversion disorder. Okay. So here, mainly there is loss of motor or sensory function. So loss of motor or sensory function means suddenly the patient will develop quadriparesis or quadriplegia. Suddenly the patient may develop aphonia. Aphonia means not able to talk. So these patients are not, it's not a factitious disorder. That means that they are not faking it, or they're not malingering. That means that they're not doing it for any secondary gain. They truly feel that they have lost the power of the arms or the legs. They truly feel that they have lost their voice. But see, this is like secondary gain, so you have to understand what is secondary gain and what is primary gain. So primary gain basically is, you, in the case of malignancy, that means that you are portraying back pain, severe back pain, so that you can get a medical certificate and say that you cannot drive for 4 weeks. Probably you have a function to attend, or you just want to rest. This is mainly primary gain, where they're clearly faking it for the sake of some returns. Secondary gain is, you suppose a person is suffering from a cancer. So most of the relatives are very empathetical, and they take care of the patients very nicely whenever this happens. So this is mainly known as secondary gain. So these conversion disorder patients mainly experience secondary gain rather than primary gain. So this is one of the more common causes of conversion disorder. That is, 25-year-old female started having an argument with his newly wed husband, and they keep shouting. They were throwing objects. Suddenly, the the female partner stopped talking. So she's basically able to move her mouth, but there is no voice production. So and they do a video laryngoscopy. They look for the vocal cord movement. During cough, the vocal cord movement is all fine. So what they suspect is psychogenic aphonia. That is, when the patient, during painful stimulus, patient is able to produce voice but is not able to talk. So this is basically conversion disorder. And one of the main thing in case of conversion disorder is labella indifference. So this may be a question sometimes asked. So what is this labella indifference? That means the patient remains indifferent to their apparent disorder. Suppose, for example, you're sleeping on the bed, and tomorrow probably your legs are not moving and your hands are not moving. So you have developed an acute quadriplegia. So you'll be shattered, because like you will have various amounts, very a huge range of emotions to discuss. Where were we? So we were at the, what is factitious disorder. Mainly factitious disorders where they intentionally produce the symptoms. So it's very important to differentiate what is factitious disorder versus malingering versus conversion disorder. Very, very commonly asked in MRCP. Next we have is dissociative disorder. So like you can see in this picture, so this is very commonly shown in all the movies that we see. It is multiple personality disorder. Okay, it is also called as dissociative identity disorder. This is another name for multiple personality disorder. So what basically happens, the science behind is, uh, so let's take for an example Ria. Okay, so this Ria is a housewife having 2 kids. So her always innate desire from childhood was to be a heroine, let's say. And whenever an acute stressor comes, what she does is she dissociates from this, homely wife to a heroine, and she starts getting ready like a heroine, and she starts auditioning, and she says that this is my personality. And she actually undergoes amnesia. That is, she she would have forgotten what would have happened to the Ria's personality. You know, she had forgotten that she was married and she had two wonderful kids. So that is separating oneself from certain memories, separating oneself from the normal consciousness. Probably Upendra movies are very famous, which portray uh, multiple personality disorders. So these were all mainly categorized as somatoform disorders. So in somatoform disorders, we have somatization disorders. Then we have hypochondriosis, where the patient thinks that he's suffering from a serious illness. Then we have the conversion disorder, then dissociative disorder. And always remember, even though it is uh, they'll always try to confuse you guys between conversion disorder with factitious disorder and what is that, malingering. So as I told you, you should be able to differentiate. Malingering has primary gains, but conversion disorders has secondary gains. So there is something called as factitious disorders by proxy. So factitious are also called as Munchausen syndrome. Okay, so Munchausen syndrome is basically, you're trying the by proxy means the mother is trying to, you know, portray that my son is having a probably a fracture. She goes keeps on going and showing to the doctor. Then again, it doesn't involve any primary gain. She's just psychologically, you know, so upset that she's intentionally producing the symptoms for attention seeking, not for any material gain. Is that point clear? So Munchausen syndrome is where the patient intentionally produces symptoms not for material gain but for attention, and malingering is for pure materialistic gain.